Welcome to The Deep End, the education podcast where we dive into current topics in emergency nursing. We will be covering updates to current practice or concepts that just need a deeper look, and we'll break it down for you. Plus, every episode we will offer contact hours, so stick around to the end and we'll tell you how to get them. All right, let's jump in. But first, a word from our sponsors. Just kidding, we're not that important. But seriously, EPR, our Emergency Physicians of the Rockies group here, our providers, have so graciously paid for our podcast. So I just want to say a quick thank you to them for doing that. That's really generous. It takes a lot of editing, to make this magic happen. So shout out to EPR. All right, let's jump into it. Hello and welcome to the Deep End podcast. I'm Jana Carlson.
And I'm Carrie Benson.
We have a super special guest today, our friend Brianna. She is a pharmacist, one of the most amazing pharmacists. I'm just going to put it out there. One of my favorites. And also working on the quality side. So she's got a lot going on the projects, and she's doing an amazing job. And we are going to talk about anaphylaxis with her today. So I'm really excited. Brianna, do you want to do a quick introduction for us?
Absolutely. Thanks for that kind intro. So I am Brianna Benson. I'm one of our ED pharmacy clinical specialists. You may have seen me around because I also am staffing at the bedside. Just some kind of background on our ED pharmacy clinical specialist position. So that is me or Scott Dietrich, if you are familiar with Scott as well. And essentially, our interest in this role and the purpose of this role is just wanting to be involved beyond more than just our bedside medication decisions. So we're a lot more involved in quality improvement, figuring out where our processes are broken, why our errors keep happening, and how we can kind of fix all these systems so the right thing is also the easy thing. Along with that, we're involved in a lot of education, working on our protocols, order sets, things like that, but we still spend a lot of our time in the emergency department making sure that everything we're doing actually translates.
Yeah, you guys have done a lot of amazing work. And I think even before you were in this role, you did a ton of process improvement. So you and I have gone down a lot of rabbit holes, and Carrie, in our time here together. So I'm super grateful for you and just the amount of work that you guys put into making things better.
This next thing that we're going to talk about has really blown my mind. I'm really excited to talk about our new practice change. So let's dive in.
Yeah, so I'm not going to lie. A couple months ago, I was like, hey, Brianna, what should we talk about on the podcast? Because I was looking for something really fun. And I mean, you guys have so many cool projects going on. And so I was like, hey, what should we talk about? And I had all these ideas. And you were like, let's talk about anaphylaxis because, a lot of changes are going to be happening. And I was like, meh. Like, that sounds so boring. So I totally put you off, and I apologize because as this started to unfold, and then I think Vanessa was presenting in one of the PEDS quality meetings, and I was like, my mind is blown. We're coming back to anaphylaxis because you actually were right. This is super interesting, and there's a lot of shift in kind of the culture that we are currently in the mindset of, I guess, and nurses that have been nurses for a long time. I think Carrie could probably speak to this too. We have such a practice in our minds of how we treat anaphylaxis and even how we define anaphylaxis. And so we wanted to get your perspective as a pharmacist. And I know you and Scott both did so much work on this. We wanted to dive in a little bit more. So talk about kind of like overarching, what's the definition of anaphylaxis that we're expecting to see more of that shift in our culture around?
Yeah, absolutely. No apologies needed because like you said, anaphylaxis is honestly like the bread and butter of our profession, right? Like there's been nothing new or riveting in a long time, but apparently we were unfortunately wrong in that. And all of us kind of just let this slip by collectively without noticing. We got this interest in kind of when we started actually getting some pushback, probably from lots of different places, but pushback from allergists in our local community who, when we were giving, say, kids Benadryl and they were going home and then seeing an allergist, the allergists were upset we had given Benadryl. And so that started filtering back to us and we started asking more questions. And so we had a lot of instrumental people in starting to ask the questions. Sarah DeBoard, Darren and Morris, the peds quality team, us here in pharmacy. And we really started looking when we found that everything was kind of different than we thought it was when you really looked. And so, anaphylaxis is tough to define. While we all know it with our eyeballs, trying to put a definition to that can be difficult, and it's a little varied. So the most simplified ways I can say we define anaphylaxis is one of two things. It's either some kind of skin involvement and the additional of one other system. So whether that's respiratory symptoms, GI symptoms, hypotension, it's basically skin plus something else. That's when we hit anaphylaxis. Additionally, a second way to define it is probably either some kind of hypotension or laryngeal involvement. So something scary with a known exposure to a trigger. So that's what we're looking for. So I know a lot of times we get these patients with just the skin reactions coming in. Those are maybe not necessarily anaphylaxis based on the definition.
That really changes a lot of what we learn traditionally in nursing school and even in our practice in the department of defining anaphylaxis. So that's kind of the first thing, is really thinking about that system involvement. So I'm really appreciating you bringing that to the forefront. I attended the BCEN conference this spring, and they had a young lady who had like 93 ED visits involving epinephrine administration for anaphylactic reactions, and her whole platform was "My symptoms don't represent what you learn in school." And she had been using that platform in this conference to teach us ED nurses to be really using our critical thinking, think outside the box of what we traditionally thought it looked like. So I'm really glad that this is coming from a system change so that we can really evaluate these patients using different methodologies. So thank you.
Absolutely.
So what are some of the main changes we're going to see with this treatment in anaphylaxis? I know we alluded to it, but this is kind of the meat and potatoes that I'm super interested in.
Absolutely. Essentially, kind of right to that culture shift, we basically realized how little data there is out there for medications that aren't epi, and just how critical it is that we get time to epi as our number one priority. We actually think that is the number one contributor to mortality, is delay to time to epi. And we kind of realized that we started bundling epi and all these other medications together, and we really unintentionally created hesitancy, right, on giving epi, because we have all these other meds, and of them, epi seems the scariest, the most serious, the big gun, so to speak. So we kind of went the wrong direction by adding all of these other adjuncts. So things that nursing is going to see is really going to be this epi first and epi only approach to anaphylaxis moving forward. So if you need other medications on your patient just comes in from triage and they move them into the room, and our first instinct is to go override the meds and get them to the room, right? And so we're overriding 4 different medications. We're overriding epi and Benadryl and Solumedrol and famotidine from this virtual kit. That is time, right? Getting every single drawer to open and remembering what it's under, right? Virtual kit, hypersensitivity, what are we typing in? So as of January 13th, ideally, the hypersensitivity kit is going to disappear. So we will no longer be overriding using a virtual hypersensitivity kit. You will just be overriding epinephrine. So rather than getting all of these medications, getting the epinephrine and getting back to the patient is going to be the most important thing.
Let's kind of pull it back to that more basic patient where we're just seeing hives with a trigger. What does that patient look like?
Yeah, what about our patients that present with hives? That's a great question, because we have a lot of those that don't have that other organ system, right? The other respiratory compromise, hypotension, GI effects. The patients that present with just hives are great candidates for antihistamines. This is the only time I'll talk about them positively. This is the time for our Benadryl or our cetirizine. Antihistamines are really great for the cutaneous symptoms. They don't help with respiratory or cardiovascular things. So this is the great time to really use those. We are moving a little bit away still in this section, away from Benadryl and towards cetirizine. So why do we care? We've been using Benadryl forever. It's easy. Dosing is easy. Everyone understands it, right? But we are getting this pushback kind of from the community in general, the academic medical community in general. But Benadryl is different, right? So we consider Benadryl a sedating antihistamine, and you might have heard that when talking about the others, Zyrtec and Allegra, all these other ones, they are non-sedating antihistamines. And the reason Benadryl is so much more sedating is it does cross the blood-brain barrier so readily. So it has so many more side effects, like sedation, impaired cognition. They say it's like having a BAL of 100, which is not a drivable BAL, and it has anticholinergic side effects. And so when you look at this, cetirizine is also an antihistamine, and it works the exact same way, right? It's the same mechanism. It has a similar onset, so we don't have to worry about it not being as fast as an IV dose of Benadryl. It has a nicer side effect profile because it doesn't cause all of those sedative effects. And it has a really long duration of action. So when we send these people home, they have 24 hours of coverage on board, and that's a huge benefit. So again, if we're kind of thinking about it, if there's no benefit on onset with that IV dose and we can avoid all of these side effects and give them more relief at home, I think cetirizine is a great option, and that is what guidelines are suggesting. So guidelines are saying to step away from Benadryl, go towards this other generation of antihistamines. And so really this is going to be the one we're going to rally for. This has been added to our order sets, stocked in our freestandings. And the only people who really aren't going to get this are going to be kids that are too young. So those under 6 months of age, they just don't have dosing for cetirizine. So you'll probably be giving IV Benadryl. People who can't tolerate oral for some reason, or if this is becoming severe and is becoming an endangered airway.
Yeah, that's a huge shift, I think, for us because we're so used to Benadryl. And thanks for the clarification on the 6 month. That was going to be my next question about pediatrics and if there was any tricky dosing or anything to know about the Zyrtec. Okay, so let's take this one step further. We do have the patient that comes in with hives and maybe nausea, vomiting. What does that patient look like?
Absolutely. So like circling back from our definition right there, now we've hit anaphylaxis, right? We have hives and we have one other system, which is our nausea vomiting, and that hits anaphylaxis. So we go to our main drug, that's epinephrine, and that would be my cue to go to the Pyxis and override epinephrine and bring that back to the room. Epinephrine is really going to be our workhorse in this situation because, like I said, while antihistamines don't work on your respiratory and your cardiac systems, Epi works on every single adrenergic receptor involved in this. It will do everything. So this is going to be the most important medication to give. So one big thing about epinephrine that I think we've also overlooked for a long time is epinephrine must be given in the thigh, and not like a must, like maybe, but we really only should be giving this in the thigh and not the delt. And think of how we educate people with EpiPens when they go home, right? That is also always to the thigh. We really should be mirroring that same thing. And the nerdy version of me is actually really excited about this topic and this pearl because there was a really great study that found that giving epinephrine in the delt doesn't actually raise your systemic epi levels any more than what your body naturally releases in response to a saline injection. It is literally placebo effect. It's just the same as your endogenous epi by getting poked and getting agitated from that. So when you get a patient, say they're brought in by EMS, the first thing you should do if EMS says they gave epi is ask where, because you need to know that information. If EMS gave it in the delt, we know that that didn't raise systemic levels. It's not therapeutic. So we can feel really safe just administering another dose right in the thigh right then. If they still look sick, you don't have to worry about it being too much epi because we have a nerdy little graph that says that they don't have any epi circulating in their body. So I would really advocate for you to start asking where they gave it in the report and then encouraging the provider to, can we give another dose in the thigh right now?
That's so interesting. I didn't know that, but I'm like thinking back to my nursing career. Was that ever really stressed that the location was important? And I don't think that it was.
Yeah, and I'm glad that you brought up advocating for that patient that might come pre-hospital. I know Dr. Vaughn is working currently on updating their protocols, but thank you for encouraging our ED nurses to take that next step and just know that we can give it again, and that's going to be just fine for that patient.
Yeah, I agree. Okay, I want to take the next step patient. So how about the patient that comes in with respiratory distress, like obvious signs of airway compromise? Walk me through, is there anything different that we would do for that patient? And I want to take it even maybe one step further to say, after we've given our IM epi, because we know that's step one. Let's say we continue to see that reaction arise over time and we're really not managing it with IM epi. What's the pathway that we are expected or expecting to follow that providers are going to go down?
Really, the backbone of it is just going to be epi again in another form, and then considering those adjunct agents a little more seriously in this very sick patient. Remember, we can repeat our epi doses up to 2 or 3 doses before we move on to an epinephrine infusion. There has been a lot of confusion about epi drips in the past, because if you see a lot of sources, the way we've historically dosed these is different units. It's confusing. It's a flat 4 mics per minute, and it's not weight-based, which is not how we dose epi for shock, right, and hypotension. So we've had a lot of issues in the past trying to reconcile that. So we did create in these order sets epinephrine-specific infusions for these serious allergic reactions where we've escalated. So it has the same dosing your nurses should be familiar with that we use for hypotension. We're going to do, the 0.05 mics per kilo per minute. Nothing changes there, but we have additional parameters to help with titration based on symptom control. So really, everything you're going to need is going to be in these order sets. It's going to have the titration parameters you want, and we'll probably just progress to more epi is the main thing. But additionally, adjunct agents, if this is really the serious patient, we probably can consider some of these other ones. So, do they need fluids for their hypotension? Not forgetting some of our basics. Are we going to use some albuterol or other things to help, depending on what their respiratory symptoms are? Steroids are kind of the hot topic at the end there, that this is one of our Hail Marys. It's another thing that we used all the time in our practice for a very long time, but there's essentially no strong evidence that this helps with any part of the anaphylaxis picture, and guidelines recommend no acute use for them in these situations. However, in these severe airway situations, or patients maybe with a history of asthma, refractory symptoms that are going the wrong way, I think this is the time that you're going to find steroids show up again.
Yeah, that's very interesting. And I think the EpiDrip thing does make everybody feel a little bit nervous. I feel nervous about that. Just thinking, even all the education we've done around Epi-IM versus Epi-IV, and now we have the drip and like the titrations and the weight-based dosing, it can be really challenging and really stressful. And so any tips as far as like from a pharmacy perspective, anything in the MAR that I should be looking for? Like how are we guiding nursing in the moment to know that they're, dosing appropriately and feel confident in what they're doing?
That's a great question. And trying to think of all things considered, I do agree. We really want to use the MAR as the source of truth in this situation, because we know there is a lot of variety on how to dose this medication, and providers might be more familiar with other dosing units. So knowing that this is built for you, knowing that the epi was maybe ordered off the order set, or going to the order set yourself to choose it would be a big one. And then again, kind of thinking this as the same as your hypotensive patient. You should be treating and dosing and titrating the same as you do for hypotension. You just have to be aware some of the things you're looking for are going to be those respiratory signs. They are going to be your skin situation. It's not going to always be hypotension. So your patient might not be that low, but we might still need to start an EpiDrip on them. And that feels weird.
That does feel weird, but I think we're going to get there. We're going to start advocating for our patients earlier on, knowing that we have the literature to support this. So we talked about 3 of those meds: steroids, Benadryl, and epinephrine. So where does H2 blockers, why are we frowning upon the use of H2 blockers in this scenario now?
Well, in another shocker of the year, we never had evidence to use them in the first place. And so we just felt really good with the fact that if we're blocking histamine over here, we should maybe also block histamine over here. And realistically, that hasn't gotten us anywhere. And so, Pepcid or famotidine has not been shown to improve any patient outcomes. It is not included in any guidelines. It is not recommended by anyone. It just makes us feel a little better about blocking all the things, but especially knowing more about Benadryl and antihistamines now. And just in general, sorry, coming from a pharmacist, our drugs aren't benign. It's trying to not expose people to medications that they don't actually need. We can come from an evidence-based place, but a lot of this has probably been coming from us being nervous.
I am just blown away. This is really all of this information. I find it exciting. I feel like it's cutting edge medicine, and I'm really looking forward to seeing how our patients respond to these new changes that we're going to do. So if as a nurse, if I'm finding that I'm getting the same old order set from physicians, how can I maybe direct them in the right direction of where they can find information on this anaphylaxis treatment?
Essentially, you should be looking for any of the order sets or order panels we've created, because we've tried to implement this and anywhere you may reach for an order for this. So we have the NOCO PEDS anaphylaxis standing orders, the ED PEDS critical illness order set, the ED anaphylaxis order set. We have changed every order set that could be involved to reflect these orders appropriately. So really the only time you're likely going to see that is, like you said, when a provider is maybe just typing in epi or using a favorite. So looking for those titled planned order sets is what you're going to want to do, because like you mentioned, this actually crossed a lot of boundaries when we started looking at this. This is now inpatient. This is also oncology, blood transfusion. Everyone's kind of changing their perspective on this. So we as a system are trying to put things more uniformly together to support that and support nurses in these situations when it is difficult to push back on decades of how we've been doing this.
Yeah, I think we can all attest to change does not happen easily, and we are the face of change usually, and so we know how it feels. It takes some time and getting used to, but I think, like Carrie said, the evidence is there, and it feels like a slam dunk to me, honestly.
Okay, so we've spent a lot of time focusing on our treatment, our monitoring, and getting the patient ready for discharge. Can you kind of guide me on what we need to be doing for discharge teaching with our patients?
Yeah, absolutely. That's a great question. And for discharging patients, one of the main things I always like to think of is making sure that they get another EpiPen, especially if they used their own or if theirs is expired at home. Say they didn't, it's just because expired at home, so they didn't use it. Making sure everyone who came in with a true allergic reaction gets out with an EpiPen. I highly encourage patients to just make sure this is refilled once a year and have it at home, because we don't want them only having expired EpiPens at home. I would just make it part of their routine at every visit once a year at their annual. Oh, by the way, can I get another EpiPen? And just fill it and bring it home and let it sit in the closet. Other things with kind of discharge counseling on the EpiPens, I always really like to encourage that everyone who would possibly take care of this patient at home knows how to use it. And like, that means grandma, that means school, that means cousin who babysits, whoever actually takes care of the person, especially a kid, knows how to give the EpiPen. So all of the teaching, the blue to the sky, orange to the thigh, holding it in place, using it in your thigh, and then massaging the area, and then calling 911 and coming in, especially in those very serious reactions. I also like to point out that in their EpiPen kits, there's 2 real ones and 1 fake. Lots of people don't realize you get a trainer in every box. And so these are really only 2 EpiPens. So whether they keep those in different locations, one in a diaper bag, one at home, one at daycare, making sure they have enough at all the locations that they may need it. A really great thing is those really little kids. So what of our tiny little peds that aren't enough for a junior EpiPen? Lots of times we're giving them 2 prescriptions. I think the best thing to do is to give them 2. If they are so little, so, less than 10, 15 kilos, they technically are too small for an EpiPen Junior, but we would never say that in real life, right? Because if they're having an anaphylactic reaction, I would rather them get too much Epi and we deal with those side effects than have no treatment whatsoever. So at default, these kids should probably still get an EpiPen Junior to get a prescription and go home with. There is a whole nother formulation of EpiPen that is meant for these kids that are this small. It is just so hard to find. So for parents of kids that are this small, I'd recommend they get both prescriptions. They get the EpiPen Junior that they can fill and use right away, and the hard copy that they can bring to pharmacies and try to get that more accurate one if they can.
Okay, that totally makes sense. And I think those are extra challenges and probably pretty rare on those really tiny kids, but that situation arises, you definitely want to have some direction on that. Were there any challenges making this change? I know this was a system push and there are so many players and so many different opinions when it comes to big system changes. I know you feel that struggle. What do you think is maybe one of the biggest challenges to implementing this practice for you guys?
I really do think the biggest challenge is going to be teaching an old dog new tricks. This is a habit for us. It is a habit. When we looked back, these recommendations have been in place since at least 2015. And honestly, I stopped looking past that. So who knows how long we've been doing it the way that we aren't supposed to. So I think really reorienting everyone and getting this buy-in, because this is the easiest thing that we take care of in some ways. The dose is the same, the meds are the same, they've been here since the dawn of time. So I think breaking this habit, it's going to take all of us to change this practice. So advocating for your patients in these situations. Oh, should we do cetirizine instead of Benadryl? Or, oh, do we need the Pepcid? Or, do we need the steroids? Getting right to Epi. I think it's going to take all of us to remind ourselves until this becomes our new habit.
Yeah, I'm not going to take offense to you calling me an old dog because I think all of us in this room right now feel like the old dog in this fight. But we've always done it this way. How do we change what we're doing? I think you're right. That's going to be a huge challenge. But if I know our nurses and our providers like I do, I know that we'll be successful, because I think once we really know that that's best for the patient, it's a pretty easy sell for me. All right, this is the last question, and I did not prep you for this.
Great.
Which everyone loves. So try this question out. Don't take it too dark, okay? Okay.
I'm intrigued.
What is your most irrational fear? This could be something that would probably really never happen in real life, but you find that it keeps you awake at night.
I love this. And I'm afraid to admit this on a podcast, to be honest, for all of my coworkers to now hear. My most irrational fear that is ridiculous is windmills. I hate those wind turbines. I think they look like the aliens from War of the Worlds, and I am ready for them to pick up legs and invade everything.
My.
They are eerie. They are terrifying. They're terrifying.
So you can't live in Wyoming, is
No,
what I'm
I
hearing.
cannot. I drive home to North Dakota every year, and I have to just look the other direction. It's not safe for anyone in the car once we get into the Dakotas. They are creepy, gigantic, quiet things. It doesn't make any sense. No, I don't like that whatsoever. So if you ever need to get to me, just, print out a picture and put it right on the computer, and you'll have an effect.
We know how to give you nightmares.
Yes. Yes.
This might be one of my favorite answers to the questions so far. We've had some good ones, but
I'm so sorry.
This one came out of left field for me, and I love it.
There's just something about them that isn't right.
Oh my. Okay, Brianna, you are fantastic and so stinking smart. And I'm so happy that we got to steal you for this 30-minute talk, because this change is going to be really exciting, and I'm super pumped about it.
Thanks, Brianna. You're a rock star. We appreciate you.
No, thank you. Thank you for having me, because honestly, this podcast is really great and exciting. I think sometimes you just need to talk it out, and things like this is incredibly helpful to really get on the same page with people you know and people you like, and understand it. An email just doesn't always do, and we get 100 of them, 1,000 of them a week, and just taking a couple minutes to talk it out is great. So thanks for doing this.
Amen. Amen to that. All right. Thank you.
Thank you.
Bye. Hey friends, thanks for joining. You can access all of the educational materials as well as a quick survey to CEs in the description for this episode below. Thanks, and see you next time.